Greetings from Alice Springs. My special thanks to Mr. John North for inviting me to present in this forum on decision making. I have particularly chosen renal dialysis patients and the surgeon's involvement with them. I would like to make some opening statements. When complications mount and the quality of life declines, and if we do not discuss prognosis and forward plan, we are subjecting our patients to more time in emergency department, ICU and hospital. Too often this results in unnecessary pain and suffering with death in the hospital. This also leads to unmet palliative care needs of the patient. And when catastrophe strikes, it is unfair and poor practice to leave all decision making to the family. Some background information. Alice Springs have a large number of patients on hemodialysis, nearly 400 at this time. These high-rise towers in this slide are the incidence of renal failure patients in NT compared to other states. This brings heavy workload to surgeons from their fistula creation and its maintenance to huge number of soft tissue infections and diabetic foot, etc. In Central Australia, the primary problem that leads to renal failure is diabetes. 80% are diabetic, 60% have severe peripheral neuropathy, and 20% have severe peripheral vascular disease. There was an article in American Journal of Nephrology in 2019 on lower extremity amputation in dialysis patient, and the salient features are lower extremity amputation predicts poor prognosis in renal patients. 1 in 10 patients with end-stage renal disease undergoes lower limb amputation in the last year of their life. The outcome is poor with the revascularization in these limbs, and lower extremity amputation is a sentinel event that predicts extremely poor prognosis. This is exactly true for our patients in Alice Springs. The dialysis patients undergone lower limb amputation leads the list of death reported from Alice Springs to NTASM. We were not planning ahead, and now we have changed our practice, and I would like to discuss the reason we changed our practice. 57-year-old lady with renal failure from Utopia, 300 kilometers away from Alice Springs. She was not engaging with the health system and started on dialysis in July 2017 after multiple discussions. She also had multiple comorbidities, diabetic with severe peripheral vascular disease, rheumatic heart disease, chronic pancreatitis with insufficiency due to alcohol abuse. She weighed only 44 kilograms and had long-standing food security and domestic violence issues. She had multiple admissions for soft tissue infections and diabetic foot infection. Timeline after dialysis is started, very frequently missing dialysis. The initial fistula got thrombosed, for which thrombectomy was done. Failed after some time. New AV graft in the right arm. It got soon infected. Prolonged admissions to ICU after multiple septic episodes. Finally, the AV graft was removed. Dialysing through tunnel lines. Meanwhile, sustained fracture of the femur. Fixation was done. Significant decline in the health. New AV graft in the right thigh, femoral to femoral AV graft. A total of 30 surgical procedures were done, 21 after starting dialysis, 200 radiology images, multiple CT, MRI and angiograms were done. Renal team had multiple family meetings with the patient and the family. No definite plan regarding NFR palliation. No conclusion was made in the meeting. Patient had literally no quality of life. 17 volumes of file with 99 admissions. The last admission to the hospital, the 99th admission, admitted under the renal team with very severe leg pain. a differential diagnosis of cellulitis, septic arthritis were made, MRI of the joint was done, surgical consultation on the 13th of November, unsalvageable ischemic leg. Patient was physiologically exhausted and miserable. We were in a difficult situation because no NFR and palliation was discussed. We had to contact the family. They want everything to be done. Above knee amputation was done. Surgery did not do any good to her. She had very severe phantom pain in the left leg. The right AV graft on the right thigh is now infected with gross swelling of the limb. She had pain in both legs. Multiple med calls for pain, sepsis, returned to theatre ICU for hypertension and sepsis. Patient is on inotropes in ICU. Due to ongoing sepsis, hypertension, finally family meeting was done. The patient is palliated and hemodialysis was withdrawn. She passed away in palliative care facility, but not peacefully. Approximate cost for her management since dialysis was $1.5 million. I presented this in the hospital mortality morbidity meeting and wanted to change our practice, and I have also reviewed some recent literature. The Journal of American Society of Nephrology 2019, this paper says that many nephrologists are not comfortable discussing end-of-life options, which results in unmet palliative care needs like in our patient. Another paper in the Clinical Journal of Nephrology recommends a palliative care approach to dialysis patient and says that nephrologists should develop expertise in discussing prognosis and goals of care. When prognosis is poor and death is expected within a year, palliative care approach should be adopted. The aim is patient comfort and not prolonging life. Non-beneficial treatment like ICU admissions, antibiotics and surgery are not offered. I may also show the images of another patient. The non-negotiable factor in all dialysis patients is that they should have an access. This patient has exhausted all her access. As the dialysis through catheter in the superior vena cava was not satisfactory, Vascath was advanced into inferior vena cava through right atrium. Unfortunately, the catheter finds its way into the liver through the hepatic veins. They wanted to check whether the catheter tip is and had to inject some dye. Unfortunately, the patient collapsed and died. I have selected these patients to highlight the difficulties we have, and if you don't discuss the prognosis with the patient, the family, and these scenarios occur very commonly. Initially, the renal team was not happy, but after some frank and open discussions, we have come to an agreement to adopt in certain patients a palliative care approach. Like patients whose access for dialysis is all exhausted, multiple admissions for sepsis, multiple operative procedures and ICU admissions, lower limb amputations, patients with progressive functional or cognitive decline and demented patients, patient who develops a severe illness that causes an abrupt decline in life expectancy. We also considered if patient misses dialysis repeatedly to take them off the program, but the team decided that it is probably not wise as many of our patients may not be in the program if we do that. Finally, my opinion is that these are difficult decisions to make and open and frank discussions are needed to make changes. Thank you.